Good afternoon, and thank you to SAGES for allowing us to present our work. This is our disclosure. None of the authors have any relevant disclosures pertaining to this particular work. So the US obesity rate for the first time last year climbed above 40%. It's kind of a scary statistic, and it appears to continue to rise. Bariatric surgery is a durable weight loss option available to our citizens to help them live longer, more healthy lives. And since around 2013, it appears the metabolic surgery of choice in the United States has become the sleeve gastrectomy, with almost 260,000 cases performed in 2019. And that represents roughly 60% of metabolic procedures in the US. Like other fields in general surgery and beyond, the robotic platform has seen increased adoption. And in this particular case, for sleeve gastrectomies, the outcomes for that adoption appear to be poorly studied. So our question was, do postoperative surgical outcomes of the robotic sleeve gastrectomy differ from the laparoscopic sleeve gastrectomy? To study that goal, we utilize a database known as the Statewide Planning and Research Cooperative System, or SPARCS, in New York State. This is an administrative database that has been mandated by the Department of Health. And so any billable procedure or clinic visit or ER visit is automatically recorded and captured by this database. There were 77,000 roughly minimally invasive sleeve gastrectomies in New York over the study period, which was 2012 to 2018. And of those, after gastrectomies for cancer and adolescent cases were removed, we were left with a sample of roughly 72,000, 2,300 of which, or 3.3%, were robotic sleeve gastrectomies. It's worth noting that it appears that the laparoscopic adoption of sleeve gastrectomy in New York State, or at least the surgeons performing those procedures, appears to be increasing year over year. But with the exception of maybe 2017 and 2018, there wasn't a commensurate jump in robotic adoption. So laparoscopy for the time being appears to be winning out. The robotic sleeve gastrectomies were more likely, slightly more likely to have private insurance and were less likely to be rural. That's likely a result of the distribution of the robotic platform and equipment within the state of New York being clustered to large urban centers and academic centers. We propensity matched based on age, sex, race, obesity, current smoking, and preoperative comorbidities such as COPD, hypertension, diabetes, and we're left with a 10-to-1 ratio between the robotic sleeve gastrectomy and 2,300 cases and 23,000 laparoscopic sleeve gastrectomies. Outcomes of note for surgeons, the length of stay appeared to be a third of a day longer for the robotic population in this series, or in this retrospective analysis. There was a 25% increase in readmissions for the robotic group. The conversion group, surprisingly, was 11 times higher. So these are patients that had either a same-day open conversion code or an open sleeve gastrectomy code on the day that their robotic code occurred. So that was 0.2 compared to 2.3. Gastrointestinal leaks were roughly equivalent, and thromboembolic events were also roughly equivalent. Regarding the charges that are also reported to this database, there appeared to be an $11,000 gap on the index admission between the robotic and the laparoscopic group, favoring the laparoscopic group, and an additional $2,000 in charges were accumulated over the next 12 months. So there was a significant, more than 30% difference in hospital charges between the groups. These significant trends that favor the laparoscopic sleeve gastrectomy in length of stay, readmissions, open conversions, and charges were noted in the unmatched sample, as well as the super morbidly obese subset analysis, and that's a group that people tend to favor the robot for. So the study limitations, of course, this is a retrospective database analysis. There's poor granularity of data in this database because it's not designed for GI or bariatric surgery. We can't tell exactly what people are doing in the operating room compared to some other databases. The rates of the observed conversions are expected to decline as surgeons get more comfortable with the equipment and it matures. And we actually did note that in 2018, that conversion rate dropped to 3-to-1, but it was still favoring laparoscopy. As a counterpoint to databases designed for obesity research or obesity surgery research, this Department of Health administrative database actually may give more realistic population findings. We found in this database that roughly 20% of readmissions actually didn't occur at the center where the surgery was performed, and so databases that focus on single centers may miss things like that, and up to 30% of non-admission visits were at other centers. The overall charges are still 30% higher for the robotic approach, and while I agree that that's probably not necessarily exactly what the final costs are, there is a correlation. And more hospital resources seem to be consumed postoperatively despite near equal rates of complications in this particular study. There was no difference in leak or thromboembolic events, so the increase at readmissions probably has more to do with the surgeon and their comfort level than actual complications. So in conclusion, at this time, at least within this database and this time period, no clear advantages emerged for the utilization of the robotic platform for either average risk or extremely obese patients. And while we do admit that new stapler technology and new robotic technology and surgeon comfort will probably push the needle in the future, this is not what we observed during this time period.